Hello, everyone. We are going to give people time to come into the webinar and then we will get started. Hello and welcome to the Myositis Association's Ask the Doc webinar series. I am Rachel Bromley. I will be your host today. I am TMA Senior Manager of Patient Education, Support, and Advocacy, and I am broadcasting from the TMA office in Columbia, Maryland. Please let us know in the chat box where you are tuning in from. TMA's Ask the Doc webinar series features a member of TMA's Medical Advisory Board or another distinguished member of the myositis medical community. As someone who lives with myositis, whether that is as a patient or care partner, you may have many questions about the condition, medications, and how to navigate the healthcare system. And sadly, perhaps your local care team has a limited understanding of myositis and how to treat it. And that can understandably make a person nervous and seek more education, and that is why TMA is here for you. This series offers you the valuable opportunity to have your questions addressed by a knowledgeable expert. It is also a way that you can then educate the community about these conditions when you share information learned during this session with your care team, family, and friends. Before we get started, we have some housekeeping notes. This webinar is being recorded and will be available on our YouTube channel on August 1st. You can go to youtube.com and search the Myositis Association and you will find us. You can also subscribe and get notifications anytime we upload a new video. Today, we have the honor of speaking with Dr. Robert Hallowell. Dr. Hallowell is a pulmonary and critical care physician at the Massachusetts General Hospital, where he is the director of the Interstitial Lung Disease Program and the Pulmonary Ambulatory Clinic. He received his medical degree from Columbia University College of Physicians and Surgeons and completed both his internal medicine residency and pulmonary critical care fellowship at Johns Hopkins Hospital. His research focuses on factors that influence outcomes in patients with various types of interstitial lung disease, otherwise known as ILD, particularly those associated with autoantibodies and rheumatologic disorders. Dr. Hallowell is also a member of the TMA Medical Advisory Board. Dr. Hallowell, welcome and thank you for being here.
Oh, thank you. It's always a pleasure to work with your community, and I really appreciate the opportunity of being invited to this safe space. It's truly an honor to be here. Thank you, Rachel.
Well, thank you so much. If you have a question for Dr. Hallowell, you can put it in the Q&A box. And yeah, let's go ahead and get started. Did you want to talk a little bit about the work you do, just a few minutes?
No, I mean, I think you gave a very nice warm
I covered
welcome
it in the bio.
that summarizes it pretty well. I'm also very involved in community engagement with our interstitial lung disease patients. I'm the medical director for the ILD Collaborative as well. Just a shameless plug for that group. So patients who have interstitial lung disease and want a really good resource, patient outreach. We have community groups as a support group like the Myositis Association for patients with interstitial lung disease. I'm heavily involved in that as well. So that's another resource if patients are looking for something there.
Before we get started on the questions that came in, would you please give us a general understanding of what interstitial lung disease is? Because I know it can be very confusing.
Yeah, no, I think that's a really good place to start because I think it can be confusing, not just to patients and caregivers, but to physicians as well, regardless of their level of training. And I think part of the problem is that there are many different terms and phrases used to describe interstitial lung disease. People hear pulmonary fibrosis, interstitial lung disease, or diffuse parenchymal lung disease. So ILD, interstitial lung disease, is a broad umbrella term, right? It's like saying there's an apple or a dog, but there's many different flavors of apple. There's many different breeds of dogs. They're not all the same, but they have some similarities. And so when we say an interstitial lung disease, we're talking about a process that affects the architecture or the meat of the lung. And so when a pulmonologist thinks about the lungs or things that can affect somebody's breathing, there's different compartments. We have the airways, right? When we breathe in, the air comes into the lungs, into the pipes, right? So the pipes of the lungs, the airways of the lungs, the trachea, the bronchi, those would be airway diseases, things like asthma or COPD or bronchitis. But then those airways, they terminate in all these tiny little air sacs or the alveoli. Think of like a bunch of grapes, right? So you have the stem of the grape, and then you have the bunches of the grapes themselves. Each of those little air sacs is where the oxygen is absorbed. Now, if you fill up those air sacs with infection or water or a problem that's like a pneumonia, that's another issue, right? That's still not interstitial lung disease. But each little air sac has a lining, right? There's the actual outside of each air sac and the space in between each air sac. That is the interstitium. And so any process that makes the lining of each air sac abnormal or the space between each little air sac abnormal, that is interstitial lung disease. So it's not a problem with the airways themselves. It's not a problem with the inside of the air sac. It's the surrounding of the air sac or the wall of each air sac. And so the problem could be inflammation. So it could be a swelling or an irritation of each little air sac that makes them thicker. It could be scar tissue around each air sac or between each air sac, and we call that fibrosis. And the reason we say fibrosis and not scar tissue is because when you use a fancier word to describe something simple, it makes you sound smarter than you are. And so if you have to think about any process that's going to make each little air sac or the space between them thicker or inflamed or irritated, it's going to make every breath feel abnormal. It's going to irritate the lungs and perhaps make you cough. And you're going to perceive that as shortness of breath or an abnormal breath, more work of breathing. And that is sort of the overall experience of an interstitial lung disease. And depending on the cause, whether it's an autoimmune process like myositis, which can affect the lungs and the interstitial area, or scar tissue that's deposited for reasons we don't understand, fancy word, idiopathic, but really just means we don't know why. There's different names that we give these interstitial lung diseases, but they really just boil down to the same thing. There's either scar tissue or inflammation in that interstitial area between or around the air sacs that doesn't belong there. And then we give it a bunch of fancy names, but that's really what it is. It's that simple.
Thank you so much. And if you have questions, please put them in the Q&A portion of your toolbar. You have a toolbar of Zoom and you should see an icon for Q&A. That's where our questions go. And then chat is for chatting with each other or sending a message to Dr. Hallowell. We do have someone that can transfer some of the questions over that have been put in the chat. And also I'm going to start with pre-submitted questions from email, and then we will just go back and forth between the live Q&A and pre-submitted, and we will get to as many as we can. All right, Dr. Hallowell, this person has antisynthetase syndrome and is curious about lung conditions in conjunction with that. Do they need a lung CAT scan on a regular basis, say every 4 to 5 years, if patients have no symptoms and the results of pulmonary function tests show small difference each time?
So this is a good question. This has been debated. So the pulmonary function tests, for the most part, are a very good screening tool for large changes in lung function and clinically significant or clinically relevant changes that we would see on a CAT scan. Meaning, if you're going to have a large amount of inflammation or a large amount of scar tissue that's going to accumulate on a CAT scan, that's enough to affect your quality of life, it should show up on the breathing tests in time. And so we often will use the breathing tests every 4 months, every 6 months, or annually, depending on how stable you are, as our sort of canary in the mine shaft or first indication for whether we need to repeat a CAT scan. So the breathing tests are good for that. That being said, I think there is a reason to get a CAT scan probably at least every 18 months to 2 years max in patients with antisynthetase syndrome or dermatomyositis, even if the breathing tests are stable. And we do that primarily for cancer screening. There is a slightly increased risk of developing growing lung nodules or lung cancer in patients who have the antisynthetase syndrome or dermatomyositis, similar to patients who have a history of smoking. And so we do recommend that patients get a CAT scan in that interval, just to make sure that there aren't any suspicious nodules that we could catch early and intervene on. Again, it's pretty rare, but if it's something that you could catch, it's recommended, because sometimes these nodules can hide in areas of scarring or fibrosis, or areas of interstitial lung disease where they can be a little hard to see. So that would be the primary reason why we wouldn't necessarily go even as long as 5 years without repeating an image, even if the patient felt perfectly.
Do you have any recommendations for non-pharmaceutical things a person with myositis-related ILD can do, such as breathing exercises and tools to help with lung recovery?
So, exercises, whether it's different types of yoga, Tai Chi, you can find all different types of breathing exercises online. There's all different patterns of breathing that you can find. I think there's value to all of those. I don't think any of them change the actual inside of the lung. So none of them are going to take away the inflammation or remove the scar, unfortunately. However, any kind of exercise, strength training, cardiovascular exercise, motion is medicine, right? Movement is medicine, whether we're talking about the muscles or the cardiovascular system, the pulmonary system. So keeping yourself active and in shape as much as you can, despite your limitations, will give you more miles per gallon, right? You only have so much, fuel in the tank, and the more efficient you can make the system, the less you are dependent on your lungs. And so if your legs are stronger and your arms are stronger and your heart is more fit, it's not going to seem as if you're running a marathon doing simple tasks. And so you're not going to be as short of breath for any given activity if the rest of your body is fit. So for that reason alone, doing as much activity as you can is helpful. Now, the breathing exercises, I think, are also important, because I think we can't underemphasize enough the importance between the brain and the body interplay and how those two are related. If I tell somebody on this call that they're going to go and give a lecture in front of 5,000 people 5 minutes from now on a topic they know nothing about, and they have to do it in their underwear, they're going to become incredibly anxious. Your heart rate's going to go up. Your respiratory rate's going to go up. You might become nauseous, right? These are physiologic changes that happen in your body because of an emotion and anxiety, right? We can't separate the body from the mind. Now, we know this intuitively, right? Because we've all felt butterflies in the stomach. We've felt our heart rate go up. We've all developed sweaty palms, right? Because of a social situation or a crush or something, right? So we know these things are linked, but we tend to forget it when we talk about disease states. And when you've been breathing normally for decades and your brain thinks it knows what a normal breath is supposed to feel like, you breathe in, you breathe out, it's supposed to be smooth, and there's supposed to be a certain elastance and stretch to your lungs. And then you develop a lung condition where the lungs are stiffer, either from inflammation or scar or some combination, or you develop muscle weakness because of different types of myositis. So now you don't have the strength you need to move your chest cage. All of a sudden, your brain says, wait a minute, something isn't right. This isn't the way my breathing has been feeling for the past 30, 40, 50, 60, 70 plus years. Something's wrong. And so the check engine light goes off, right? And you interpret that check engine light going off as shortness of breath or dyspnea, as we call it. And so you need to retrain your brain to accept this new normal as much as you can and get used to a different breathing pattern so that it doesn't feel as abnormal to you. And it's not going to be perfect, but there is a mental component here. Now, that's not to say that your shortness of breath is all in your head, because it's a true physiologic change. But there is an adaptation. And I think part of that adaptation isn't just, oh, have some medications. I think part of it is mind-body feedback. And some of these breathing exercises, I think, can be quite helpful for that, whether it's meditation with breathing, yoga with breathing, getting your body more accustomed to this sensation, saying, I feel short of breath, but my oxygen level is now okay because I'm on oxygen, or I feel the shortness of breath, but I'm in a safe space. I'm not being chased by a saber-toothed lion. I'm not being attacked, even though it invokes the same kind of anxiety or fear as if I was being chased by something, because it all goes to the amygdala. It all goes to the same parts of the old brain, and sort of retraining that circuitry. And so I do think that's where those breathing exercises come in handy, to sort of reground the body and mind. And that can make some of these conditions, which can be really a struggle to deal with, a little bit more tolerable, and can improve quality of life. And this is something we're doing a little bit of research on here. And I think a lot more work needs to be done, because it's not all just about popping pills and improving forced vital capacities in clinical trials. I think it's more about a bigger picture, whether it's talking about the muscle disease or the lung component.
This person tested high for MDA5, but so far their lungs are clear. Should they start seeing a pulmonologist now or hope for the best? They don't even know what to look for if ILD is in my future. How do I know it is time to see a pulmonologist?
Yeah. Well, MDA5 is something we're very passionate about here, and we have an active research program looking at the importance of MDA5 and the whole spectrum of lung disease that comes with it, because it used to be thought that MDA5 was only associated with severe, rapidly progressive lung disease. And we're debunking that. And I think this is a perfect case, a perfect example. So yes, just because you have an MDA5 antibody or any of these antibodies does not mean that you're going to develop severe lung disease or any lung disease. So, I don't know if there's a right answer. If you don't have lung disease currently, I don't know that a pulmonologist right now is going to do anything. So, I mean, there's nothing for a pulmonologist to do yet. I think at this stage, either a rheumatologist or even a primary care physician would be well positioned to do the initial screening. I don't think it would be unreasonable. Now, there's no guidelines officially for this, although we did just come out with new American College of Rheumatology guidelines that was part of. I would say that it's not unreasonable to do breathing tests, annual breathing tests, if your breathing feels fine or stable, to continue with an annual breathing test to see if there's any change or difference. And if that stays stable, and there's no concerns there, that's probably adequate. But if there's any change in anything or any whisper or signs that anything is developing, I think I would have a very low threshold to get pulmonary involved, and they would be happy to see you.
Thank you so much. Now let's get to some live questions that have been put in the Q&A box. How often do you recommend imaging if you aren't experiencing respiratory symptoms? I believe you pretty much covered some of that in your last question. This person's PFTs are mostly within normal range, but PFTs seem like a lagging indicator, so I don't want to wait until I can feel the bad effects to get imaging.
Yeah, yes, I touched upon that a little bit. So the one comment I'll make, so interestingly, PFTs, depending on the part of the PFT, um,
Can you
PFT,
tell everybody what PFTs are?
oh,
Because
yes,
not
yes,
everyone
sorry.
knows.
Yes, see, here I am throwing around lingo. That's just to make myself seem smarter than I am.
Yeah.
So, so
I think your
pulmonary,
CV has Harvard on it somewhere.
that
I
means
think
nothing.
I saw that.
Um, so pulmonary function testing, right? So, this is where we put you into a box or into a room and they put this big snorkel in your mouth like this, and they pinch your nose and you blow into this machine. And so we measure a few things when we do that. One is we have you take the biggest breath you can and exhale into the machine to see the size of your breath, what we call your forced vital capacity. The idea being that as interstitial lung disease progresses, the size of the breath you exhale gets smaller over time if the lungs are getting stiffer. And so that's one measure. Um, that number, I agree with the person who asked this question. That number, the vital capacity or the size of your breath, that can lag. It takes a lot for that number to go down. And so it is possible to have subtle changes in interstitial lung disease worsening on a CAT scan before that number would change. And so it's not a very sensitive number, as we would say. So I don't put a lot of faith in that as being an early warning sign. The other thing we check on the breathing test is what's called the diffusion capacity, or the DLCO. And this is where we have you hold your breath on the machine for about 10 seconds to see how well you absorb a gas into your lungs or how well you would absorb oxygen. We use carbon monoxide as a surrogate, but it's to mimic oxygen absorption. And so you could imagine as interstitial lung disease progresses, if you have more inflammation or more scar tissue in the way, it's harder to absorb oxygen through those little air sacs. And so that number, that value is actually quite sensitive and a pretty good indicator. And so we'll see changes in that number oftentimes well before we'll see a change on a CAT scan, because things will happen on a molecular or a cellular level in the lungs that will affect that test even before we can see something changing on a CAT scan. But that test has wild swings. There's a big margin of error on that test. And so it can be very noisy. And it can be hard to tell if a change is real or just like a daily variation or a technician variation. So it's not as reliable, even though it's pretty sensitive. So I think getting back to the point in terms of CAT scans, I think we use the breathing tests as sort of an initial pass. But if we see any significant change in the breathing tests, usually we say more than 10%, and a patient's having any change in their breathing, that would trigger a repeat CAT scan. If we just see a small change in the breathing tests and it seems like it could just be a blip, we'll often just repeat the breathing test, especially if the patient feels the same. If that change persists or continues to go in the wrong direction, that would trigger a CAT scan. So we try not to do too many CAT scans because you can imagine, little blips here and there. Before you know it, you're getting a CAT scan every couple months, and now you're glowing at night like glowworm, that old toy we used to have. So we don't want to give you so much radiation that we're getting all these scans indiscriminately. But we are mindful that if we start to see a change that's concerning, we would jump to a CAT scan to confirm it. But to my previous point, if PFTs are always, or the breathing tests are always kind of relatively stable for more than a year and a half, hitting 2 years, we would get a CAT scan anyway, just to make sure we're not missing any new spots or specks or nodules on the lungs that would be concerning for either a precancerous spot or anything else that we would want to monitor, kind of the way a dermatologist looks at moles on the skin over time.
We have a couple of questions about supplements and if there are any that can improve ILD conditions or symptoms.
Yes, I'm glad you brought that up. So I don't know if some supplements can be helpful. You know, a lot of medicines throughout history in Western medicine have come from nature. Um, we would not have penicillin if it wasn't for mold. We wouldn't have digitoxin if it wasn't for foxglove. Um, the list goes on and on. We wouldn't have developed lidocaine if it wasn't for cocoa leaves and cocaine, right? I mean, name a drug, and many of them are natural, or were natural before we came up with synthetics. Um, so I'm not anti natural things and looking to nature. I think nature probably has a solution to everything if we look hard enough. However, there are many supplements out there that actually have profound effects on the immune system, and especially some of them that um, posit to boost the immune system or work on the immune system. And a lot of our patients who have myositis or interstitial lung disease who are taking immune suppression want to take supplements to keep themselves healthy or help their immune system at the same time. And this can actually be quite dangerous because one of our Myositis Association board members, Dr. Worth, actually at University of Pennsylvania, has done some work on this. And it turns out that some of these supplements can actually significantly increase your risk of having a flare-up or an exacerbation of your interstitial lung disease or your myositis, because they do have an impact on the immune system and they can rev it up and have some really bad consequences. So, I think there's a lot to learn from supplements and natural medicine and things people have used throughout history. But I'm very hesitant because we don't know what some of these things have in them and how they interact with other medications and how they interact with the immune system. And I think there's also a potential to do harm there. So I get very weary of those things. And that's probably the most specific answer I can give at this point.
Thank you. Is it possible to experience joint pain as a symptom of antisynthetase without further lung damage being done? Or is it more likely that because joint pain is a marker of disease activity, that if I'm experiencing joint pain, that further lung damage is being done? In other words, do the two symptoms move in tandem, assuming I've been diagnosed with ILD?
This is a great teaching point. Joint pains are very common with the antisynthetase syndrome or dermatomyositis. Any rheumatologic condition in general can give you joint pains. In fact, a lot of our patients are initially diagnosed with rheumatoid arthritis, and they don't have rheumatoid arthritis. They, in fact, have antisynthetase syndrome or dermatomyositis, and they have a joint manifestation on top of it. The lung disease can come later. Sometimes the lung disease comes first and then the joint pains come, right? So these things can come at any time. They have nothing to do with each other. So the joint pains can be a sign of more systemic or non-lung component of the disease. But just because you have poorly controlled joint pains or rip-roaring arthritis or really bad skin disease or really bad muscle disease, that does not tell me what's going on in the lungs, and vice versa. So the lungs march to the beat of a different drummer. We have patients where they have horrendous joint pain, horrible skin disease, really bad muscle disease. They don't have any lung problems, or their lung disease used to be a problem and is now quiescent, stable, perfect. And then vice versa, right? We have patients where we put them on medications and their joints get better, their skin gets better, or their muscle gets better, but for some reason their lungs are a problem and keep trying to get worse, and we have to keep treating just the lungs. So one doesn't tell me about the other. And so we can have rheumatology feeling happy and high-fiving that that stuff is good, and then I have to be really worried about the lungs and vice versa. So every team member, the muscle group, the rheumatologist, neurology, pulmonary, we all have to watch our own organ systems and due diligence. We can't rely on everybody else. We all have to communicate, but we all keep watch.
Is ILD an autoimmune in and of itself, or is it a symptom within the dermatomyositis diagnosis?
Yeah. So in patients who have myositis, it is thought to be all part of the same process. So when you have dermatomyositis or the antisynthetase syndrome or polymyositis, et cetera, it's thought that there is an autoimmune process in the body, and that autoimmune process picks and chooses which parts of the body to affect. The immune system runs throughout our whole body, and for some reason, it picks and chooses which parts of the body to impact. Sometimes the skin, sometimes the joints, sometimes the muscles, sometimes the lungs. And so it's the same autoimmune process throughout the body. It just sometimes is affecting the lung tissue. There are cases where there is an autoimmune process only in the lungs and we don't see it anywhere else. And sometimes patients don't have blood markers or antibodies that we can give it a name. My suspicion is that someday we'll find another antibody and another name for that, and we're just not sophisticated enough. But autoimmunity is autoimmunity. And so I think the lungs end up being the innocent bystander of an autoimmune process. That's sort of the best way I would describe it.
We've got some medication questions. For instance, does Ruxtein, I don't think that's correct, or that may be a name I'm not familiar with, help with interstitial lung disease? And I believe someone else is on methotrexate. Did you just want to talk about medications in general?
Yeah. So I think folks are probably referring to medications like Rituxan or rituximab, methotrexate, cyclophosphamide, mycophenolate, tacrolimus, right? There's a whole litany of medications that rheumatology will use to treat myositis. These are all medications that target the immune system to reduce inflammation and to reduce the autoimmune component. So they all work in different ways on either the B cells or the T cells or the plasma cells, different types of white blood cells in the immune system. As a general rule of thumb, medications that will treat the muscles will treat the lungs to a varying extent. They will also treat the skin to a varying extent and the joints to varying extents. Now, there's some exceptions. Some medicines are better for the joints than they are for the lungs, or better for the lungs than they are for the joints. But for the most part, they all have a similar idea, a similar effect. And we pick and choose them sometimes depending on whether we're treating somebody with rheumatoid arthritis versus scleroderma versus myositis. Sometimes depending on the antibody that's in the blood. We think maybe one medication is better than another, but we don't have great studies to tell us that because these conditions are pretty rare. And so the evidence isn't great, but this is, one of the things that we're studying.
Well, within your patients, we have someone that's asking if methotrexate can exacerbate ILD. Have you seen that?
Yeah, so back in the day, so it used to be thought that methotrexate was a big cause of interstitial lung disease. And this was because methotrexate was used to treat rheumatoid arthritis. It was the primary treatment for rheumatoid arthritis. And patients with rheumatoid arthritis notoriously get interstitial lung disease. And so the medication was blamed for the interstitial lung disease. It turns out that the worse your rheumatoid arthritis, the greater the risk of developing interstitial lung disease. And the worse your rheumatoid arthritis, the more you needed a medicine like methotrexate. And so it was an association, but not a cause. And so the methotrexate wasn't causing the interstitial lung disease. It's just those patients were going to get the interstitial lung disease anyway, and they happened to be put on methotrexate. What we now know is that the more you control the rheumatoid arthritis, the lower the chances of getting subsequent interstitial lung disease. And methotrexate, for most patients with an autoimmune condition like RA, rheumatoid arthritis, methotrexate is actually protective and prevents interstitial lung disease in those patients, since we were able to do real studies. Now, there is a rare exception. So in rare cases, and this was a study done at Hopkins by another TMA board member, Dr. Danoff, who will be speaking at the upcoming meeting in Baltimore this fall. Dr. Danoff's group at Hopkins looked at methotrexate in patients with myositis, and they found that it does not cause interstitial lung disease, but there's a rare incidence, 1 to 2%, of causing inflammation or pneumonitis, which is different than progressive scarring type interstitial lung disease. So for the most part, methotrexate is thought to be safe and effective for patients who have myositis, and we can use it in patients who have lung disease. If there's other alternatives, we can use those. But if methotrexate is needed or effective for the joints or the muscles, et cetera, we certainly can use it. We have used it. It's been used for decades and is an option. As an aside, for sarcoidosis, which is another lung disease, autoimmune condition, methotrexate is the first line therapy to treat the lungs in that situation. So it's certainly something that we use to treat the lungs.
Is daily use of Symbicort used to prevent a flare of ILD?
It's typically not. So Symbicort is a medication. It's an inhaler. Some of you may have heard of this or seen it or are taking it. It's an inhaler that has 2 medications in it. It's used to treat asthma and COPD in general. One medication in it is what's called a bronchodilator. So it's a long-acting version of albuterol. So a long-acting version of a medication that opens up the airways. And so interstitial lung disease is not an airway disease, right? We talked about that. It's spaces around the air sacs and between the air sacs. So it has nothing to do with the airways. So the first component in Symbicort opens up the larger airways. The second component in Symbicort is an inhaled steroid, with the thought being of reducing inflammation of the airways in people who have asthma or COPD. Again, most of that steroid does not make it all the way down into the deep, dark depths of the lung where the interstitium is or where interstitial lung disease takes place. And so that probably explains why it's not very helpful for treating interstitial lung disease. And the dose of steroid delivered to the lung is actually quite low. So as a general rule, we're not using inhaled steroids, such as found in Symbicort, to treat interstitial lung disease or prevent flare-ups. That being said, just because you have interstitial lung disease does not mean you are protected from developing asthma or COPD. And just because you develop interstitial lung disease later in life does not mean that you didn't have asthma previously as a younger adult or in childhood or COPD. And so people can have both. And so sometimes the Symbicort is treating the asthma component or the COPD component, which can also cause shortness of breath, some wheezing or coughing. And so it can be useful for that part, but it's not really having an impact on the interstitial lung disease component itself.
Have there been any studies or articles about using JAK inhibitors to treat ILD?
Yeah, so this is a new hot topic. So JAK inhibitors, so the JAK pathway is within the cell, within immune cells. When a cell sees an infection or sees inflammation, specifically the white blood cells, there's this like communication of different signals and chemicals inside the cell that tells it turn on, turn off, do good stuff, cause inflammation, et cetera. And so JAK, J-A-K, is just one of these molecules in the cell that turns on a bunch of switches, right? So turn on this switch and then this switch and then this switch. It's like Morse code in the cell. And so JAK inhibitors is a way of turning off part of the communication within the white blood cells to turn down the immune system. And so one of these medicines, Xeljanz, I think is the brand name, or tofacitinib. Don't ask me who comes up with these names. they get paid a lot of money to do so, but they come up with the strangest names ever. But
And
tofacitinib,
they're all hard to pronounce
they're all hard
too,
to pronounce. I
right? Well,
know.
that's because they're
Why?
running out of words and alphabet letters,
Well,
right?
and because the harder the word is to pronounce, the smarter you sound if you can actually say it. But so tofacitinib is the main one, and this drug was used predominantly in patients with rheumatoid arthritis. It's quite effective for controlling joint disease, um, but it comes with a black box warning. A black box warning is something the FDA puts out. It's literally a black box of writing on the label that says, like, warning, this medication may cause death or stroke or something horrible in the patient based on studies. Use at your own risk, kind of thing. And so the JAK inhibitor class in patients with rheumatoid arthritis can cause cardiovascular events, so stroke, heart attack, etc. Um, and so it was used with caution. Now, it wasn't all patients, and you have to like look at the studies carefully. So we use them if we need to, but we haven't been using them as liberally as some of the other medicines. Now, what's intriguing about them, though, is that in patients who have very severe or refractory myositis-related interstitial lung disease, MDA5 related, patients who are in the hospital, patients who are in the ICU, there are some studies showing that these medications could be quite effective and life-saving compared to other medicines that are failing. But these are small studies, and we have to take them with a grain of salt. So, I think there's a place for them. I think they might be useful. If there's a 1 or 2% risk of a heart attack or a stroke with this medication over a few years, but somebody is critically ill or very, very sick from a condition that is, making them die in an ICU, let's say, then I think there's a benefit there. So I think there's a lot more to be learned about them. And the black box warning, probably needs to be studied more because their true safety, I think, also needs to be teased out. I think you're going to hear a lot more about them as we use them more and learn more about just how safe they are, how effective they are. But it is sort of a hot topic and something that has garnered a lot of interest and discussion.
This person has been on CellCept for 6 years and would like to know what is the impact of CellCept on their ILD and DM.
Yeah. So the CellCept, generic name is mycophenolate. For those of you who are on most of it's generic now, or Myfortic is sort of the enteric coded version. So this medication works on essentially T cells, so part of the white blood cells, and it suppresses the immune system. It's effective for skin disease and muscle disease and lung disease. So it's probably our go-to first-line therapy to treat many, many different types of interstitial lung diseases, regardless of the cause. So whether it's rheumatoid arthritis, scleroderma, myositis, it's sort of like the workhorse of the rheumatology and pulmonary fields for interstitial lung disease. So it can be very effective at reversing inflammation in the lungs and keeping that inflammation in check. And patients can be on it long term. It's relatively safe in terms of infection risk, et cetera. Over time, we'll often try to wean patients off if they can, if they're able to. But as in this case, we have patients who are on it, for very long term. Incidentally, it's also one of the main medications used in patients who receive an organ transplant. So kidney transplant, lung transplant, liver transplant. It's one of the medications that patients will remain on for life in order to prevent rejection of the organ. And so we know patients can remain on it long term. We have quite a bit of experience with that.
This person is living with DM and they are experiencing increasing joint pain. Is ibuprofen the best for this, or is there a better medication to take for aches and pains?
I think ibuprofen can be effective, but there's a limit as to how much you can take, and one has to be mindful of stomach upset, ulcers, and kidney function, et cetera. But the joint pain could be a manifestation of the dermatomyositis if it's an inflammation of the joints. And so it's probably worth having a conversation with your rheumatologist about the joint pain to make sure that you're not missing something there. And, it might be a tweaking of medication or using a different medication than what you're on to get better joint coverage if that's, reaching a point where it's impacting your life. And sometimes it's just osteoarthritis from aging, depending on how old the person is or what their lifestyle is. But if it's an inflammation of the joints from the dermatomyositis, that might require a change in medication depending on the severity.
Okay. Does A1AT have any effect on the lungs?
A1AT.
I don't know what that is either. Let me ask you another question while you Google that.
Yeah, let me see.
Um,
Oh, maybe alpha-1 antitrypsin. But I'm not sure if was that was that in the chat?
it's in the Q&A. But that person can add anything in the Q&A if they want to give us a little bit of clarification on the A1AT. While we're waiting on that, what is your opinion on the breathing exercise called bellows breathing? Does it improve lung capacity?
Um, Probably not in the sense of what we would see on our pulmonary function testing, because that testing really gets at the meat of the lung and the compliance or stretch capacity of the lung. But to my previous point, I think that kind of breathing can strengthen respiratory muscles a little bit. So it could have a slight impact on the breathing test. More importantly, I think it can improve patients' breathing awareness and comfortability, if that's a word, with their breathing and sensation of breathing. So I do think there's benefit to those kind of practices.
They're also
How
asking
much it actually
about,
changes, I don't know that anybody's looked at the actual impact of those breathing activities on pulmonary function testing, which maybe is something we should do. I'd be interested to see, patient experience and subjective qualitative reports in terms of breathing and how patients feel versus is there actually an objective change on the breathing test from, let's say 6 weeks of doing bellows breathing or some other breathing exercise. I think that'd actually be a pretty neat thing to look at.
well, we have another TMA MAB member who loves to talk about singing for lung health. Have
Yeah.
you got any guidance on that
Well,
beyond
I
just
think it's
doing it in the shower?
so I mean, you can't stop me from belting Taylor Swift in the car on my way to work. So I think there's a few benefits to singing. One, I think it's exercise, right? It's breathing exercise. So it's one of these breathing techniques, and forces you to use your diaphragm, et cetera. And it's patients also get an objective measure of how their breathing is doing, right? And it's another way of being active in terms of, I used to be able to, last week I could sing this song and get through that verse, or I could hold that note long enough to match Taylor in, Dear John, my favorite song. And today I can't. Why? Right. And that may be the first sign that something's changing, right? And so, these little things are important because catching a flare up in lung disease or catching something that's different in the breathing early is important. And if you have muscle disease or you're not going to the gym every day, you may not notice a change in your breathing early on. But if you're singing and you like to sing and you notice, hey, I can't hit that note anymore. I could do it last week, or I can't sing as long as I used to, or I have to catch my breath, at this point, and I wasn't doing that last week. That could be the first sign that like maybe I should pay a little more attention or to my saturations or talk to my doctor. So I think it's valuable there. It's actually objective information. It also, back to the like breathing exercises, in a safe way, it gets you used to a new sensation of your breathing. Like, hey, I don't feel as comfortable as I used to with my breathing. I can't hold a note as long as I used to when I was younger, or my breathing was healthier. That could be an upsetting thing, but I'm not going to be upset about it because I'm singing Taylor Swift right now. And so you're taking a negative and you're putting it with a positive emotion, and you're forming a new relationship. And there's a really good movie called Inside Out.
I
And
saw Inside Out 2 just last night.
yeah, so for those who haven't seen it, it's a beautiful movie. And the part of the movie, there's inside the voice, there's joy and there's sadness, and they're always apart. And the idea is you actually need both, right? You bring them together and it forms a more complex, beautiful person. And you're part of the adaptation to dyspnea or shortness of breath is realizing that you need to like you got to try to make the most of this. And so I think part of singing when you have a respiratory disease is saying, well, I can still do this, and you're bringing in a positive aspect to this, and I think it helps you adapt a little bit. So I think there's that. And then singing in general just releases endorphins and makes people feel better. And when you feel better and are happier or less depressed or less anxious, I think you are less short of breath, because negative emotions will make any negative physical sensation, whether it's pain or shortness of breath, feel worse. So for all those reasons, I think we should all go sing something when we end this call, whether you have a terrible voice or a
We
great
do
voice.
a Disney sing-along. We did that at one conference, at the
Yes.
reception. It was a lot of fun, and we all wore Mickey Mouse ears.
I'm a Frozen 2 person,
Oh,
but
yeah, you were there for that one. Okay, the person that wanted to know about A1AT has IBM, and they are, and I know you don't see IBMers in general, but they're curious about how it affects the muscles used in breathing. They have an elevated diaphragm,
yeah,
and they understand that alpha-1 antitrypsin protein made in the liver is supposed to protect the lungs.
yes.
So,
Yeah. Great questions. We breathe with our muscles, right? The only reason we can breathe is because we need muscle strength to move the diaphragm and the other muscles of respiration to expand the chest cage. The pressure inside the chest cage drops because you're creating a bigger volume, and that negative pressure allows air to come in, right? So if you have a muscle condition, whether it's inclusion body myositis, or you paralyze a diaphragm from a wound, or you have ALS, or you have some other muscle weakness, no matter what it is, malnutrition, you name it, your breathing is affected. And the inability to move your diaphragm appropriately, for any reason, will cause shortness of breath. So you don't need interstitial lung disease with your myositis to feel winded. You don't need interstitial lung disease from any type of myositis to have abnormal breathing tests, right? So if your respiratory muscles are getting weaker, your forced vital capacity on your breathing test will go down. And you'll see that. And we can see weakness on breathing tests. There's different maneuvers we can do. So that will absolutely impact your breathing, and make it harder for you to get around without feeling winded. Even if your oxygen levels are perfectly normal, right? Your CAT scan may look perfectly normal, but you're not going to feel normal. And it's going to be really tough. Now, alpha-1 antitrypsin, that's an enzyme. It is made, it's an enzyme that protects both the liver and the lungs. And so most of us have two normal copies, one from mom, one from dad, and the enzyme sits in the lungs and the liver and prevents those from getting damaged. Patients who get an abnormal copy, who have a mutation, especially if you have two abnormal copies, you don't make this enzyme. And so the lungs are very susceptible to damage. Now, if you're not a smoker or you don't live in a city with a lot of pollution, oftentimes your lungs are fine. But if you do smoke, especially, these patients get emphysema or destruction of the lung from smoking with very little smoke exposure. So they can, only smoke for 5-10 years and look like they've smoked for 80 years. So it's really profound because that enzyme is protective. And then patients also, their liver gets damaged from, the food they eat or alcohol they drink or Tylenol they take. And so these patients get liver damage or cirrhosis or scarring of the liver over time if they're not careful from not having this protective enzyme. And so sometimes, if we see a certain pattern on a CAT scan, unexplained emphysema or air sac destruction of the lungs, we'll screen patients to see if they have abnormal alpha-1 antitrypsin levels or genetic mutations in that. And that's sort of how those two go together.
This person is looking at the ILD guidelines by ACR for 2023, and it says ambulatory desaturation testing every 3 to 12 months. What is that?
Yeah. So we were, I was on those guidelines. That's one of the things I'd referenced earlier. That's the one. So ambulatory saturation, this is kind of controversial of how useful it is, but I think it's actually useful. So I agree with this. So this is where your doctor in the clinic puts the oxygen probe on your finger and has you walk around the clinic kind of at your pace to see whether or not your oxygen levels go down. And so if your oxygen level stays in the upper 90s, the chances of you having any significant lung disease are extremely low. But if those numbers go down, if they used to be 97 and then you walk a couple laps and now it goes down to 92%, there's something abnormal with the lungs often. And so that would prompt breathing tests and maybe a CAT scan for early detection of interstitial lung disease. Patients who already have interstitial lung disease diagnosed, we often will check that anyway on occasion to make sure patients don't need oxygen. But as a screening test, that can sometimes be helpful at detecting early lung disease.
Matt, in your opinion, does lap swimming help to improve lung capacity?
So I would put it with other forms of exercise. I think it's a great way to get exercise. And again, I think this would go with, it probably, it doesn't change the lung architecture or what the lungs look like on a CAT scan. I will say people who swim or play the flute or a wind instrument, they can definitely hold their breath longer, hold a note longer. They probably outperform their peers on a breathing test, but I don't think it's been studied. That'd be interesting to see. But I would imagine that doing exercises that require you to focus on the breath, like singing, but swimming especially, you have to focus on your breathing when you're swimming. You can't just breathe whenever you want to, right? So you have to get into a cadence. There's probably an added benefit to that in addition to just the cardiovascular piece, because you have to kind of be in tune with your breath and accepting of what it's going to feel like, even if it's not normal. So for many reasons, swimming is excellent exercise. And I think patients who have a lung disease, if they're able to do it safely, it's probably really good.
Well, thank you. We have time for one more question. Any thoughts on CAR T therapy for antisynthetase syndrome / ILD as a result of autoimmune disease, and any predictions for timeline? You might be psychic, when it'll be widely available if it is proven to work.
This is a hot topic. These are all great questions, by the way. I think this is a very sophisticated audience. As always, I know that from going to the conferences. So CAR T therapy is really smart medicine. It's probably the future of a lot of medicine. People talk about like stem cells and this and that has not panned out to be the future of much. This actually is the future of a lot of stuff, and it's already in practice for oncology. And what they do is they harvest white blood cells, your T cells, and they essentially train them to be soldiers against a target and put them back into your body. So for cancer, they take T cells, which have little receptors on their surface, and they train those T cells and clone them into an army to go back into your body and attack whatever cancer you have, which is brilliant. And so that's being parlayed into autoimmune conditions where, instead of using a certain therapy like rituximab or mycophenolate or these, immune suppressing therapies to knock down a certain, cell line in your blood to reduce your immune system, we can train these T cells to either reduce a certain antibody in the blood, or reduce a certain type of T cell or white blood cell in the blood that we think is attacking your own body. So we can kind of arm your immune system or train your immune system in a certain way. So it's really quite clever. It's currently pretty expensive, but that'll come down, and we're gaining a lot of experience with it. If it goes wrong, patients can get pretty sick from it. So it's still not like a free lunch. And so it's really only reserved for the sickest of cases, where all other things have been tried and failed, because you can get, really bad neurologic sickness and or other problems with it if there's a complication. So right now it's being used at a few centers around the country for autoimmune conditions like myositis in a research setting. I would not be surprised if we saw this rolling out in the next 5 years. To be honest, like I mean, it's here. We've been doing it in the cancer world for many years now, and it's routine. On a weekly basis, we have patients coming through getting CAR T therapy. So it's not like we don't know how to do it. It's not a new technology. It's just a new application. So I think it's here. I think we'll probably get better with it. I haven't used it myself yet, but we're excited to learn more about it for this application. So stay tuned.
We are over time. Do you have time for just one more?
Of course.
Okay. Getting diagnosed with ILD can be a very scary experience. What do you tell your patients after their diagnosis to comfort them?
Yeah. I mean, every patient is different. I think it depends on what the diagnosis is and sort of what the picture looks like. You can imagine I see a wide range of patients coming in, a full spectrum, and I think the conversation is going to vary. But there's a common theme here. And I think the first thing is that you're not dying, right? You're living with a chronic condition. You're living with a condition that understandably incites anxiety and fear, and may come with some lifestyle changes. It may not, depending on your situation. But there's often more question marks than answers. And, it's our human nature to jump to the worst possible conclusion. We all do this. We create a future in our heads that doesn't exist. We see what's going to happen. We make a timeline. We get our affairs in order, et cetera. I mean, planning's important, but none of us can see the future. And most of the patients I see come in and they tell me, I know I'm going to be dead in 3 years. What can you do for me? And I mean, I have a whole clinic filled with ghosts then, because almost none of my patients are dead in 3 years. It just is not what happens. And so, I tell most of them after I do an exam that I have not found an expiration date stamped on them. And the goal is to live with this, not die from this. And this is not the defining feature. And I don't think that's false hope. I think that's just a way of living and a way of looking at the condition. And, none of us are immune to illness. Not me, not doctors. we all are going to unfortunately get sick in some context. And unfortunately, we're all going to, at some point, die of an illness. And our jobs here, I think, are to focus on the things that matter within the health realm, and keep things in a perspective that allows us to continue living our best lives, um, with an eye on the prize. And it's not always the amount of medications we can take and the breathing test result. Um, and I think it's going to be a journey, right? It's going to be a journey. We want to make it as long as we can, but we also want it to be as good as possible. And then I also would emphasize again that there's power in community, and I think knowing that there's other patients who are going through what you're going through, being a part of something like the Myositis Association, is very empowering. And so I encourage my myositis patients to join this organization. I encourage my ILD patients to join the ILD Collaborative or some other ILD group, if they're into that kind of thing, to have a sense of community, and a safe space where they can talk to other people. Because I think that's important, because it's very isolating, right? Nobody understands what you're going through but you, right? Your family doesn't get it. They try, but they can't be your therapist, your support group, right? They can do the best they can, but nobody knows, right? Nobody knows what it's like to not be able to breathe or walk the way you want to walk, right? And so I think having that community really, really matters. And so I would
Thank
say
you
most of
so
our visits,
much.
most of our visits involve some aspect of them.
Well, someone in chat asked if we could clone you. So if you could give us a timeline on that project, that
Well,
would be
I'm actually an
great.
AI generated bot.
Oh,
So I'm not even human. So welcome to the future, everyone.
you have a lot of empathy for an AI person. That's
Yes, I've been
great.
coded that way.
Well, thank you so much for giving of your time and expertise in today's webinar. We really appreciate you. And to those of you in the audience, thank you for participating in today's webinar. We are over time. I'm sorry we couldn't get to all the questions. You are free to still send them to me at rachel@myositis.org. Please join us for TMA's next webinar on July 25th at 4 p.m. Eastern. It's a special TMA Meet and Greet Leadership Series edition. We also would like to give you a personal invitation to attend our monthly support and affinity groups. And Dr. Hallowell gave us the perfect segue into that. Research has shown that people who receive support from a social network cope better, feel more in control, and have better outcomes than those who are isolated. Those who live with myositis, however, face the difficulty of dealing with a chronic illness, plus the extra challenge of having a rare disease that most people have never heard of. And because of this, it is so important to find others in your circle. And that's why we're also excited to let you know that our TMA nationwide support group that meets on the first Saturday of every month and has breakout rooms by diagnosis, has added an ILD group to that. So you can go and talk to other people. And what we've noticed is that people may attend their main diagnosis if their ILD is not bothering them. And then if their ILD is bothering them, then they switch. And you can always go, you can hop around in the breakout room. So that's the third Saturday of every month at 1 p.m. Eastern. And you can register for any of these events at www.myositis.org at our events calendar. TMA is an inclusive community and invites you to reach out as you need and go to as many groups or meetings as you want. Even if you see it's from New Jersey and you live in Idaho, you can still attend that meeting. So thank you so much. And I'm Rachel Bromley. Enjoy the rest of your day.